Good evening, good morning, good afternoon, wherever you are. Thanks for participating in the Asia Pacific Glaucoma Society webinar on clinical conundrums in glaucoma practice. We thank Allergan for their kind support to support this webinar. I am Nazrul Islam from Bangladesh. I will be moderating this session along with my esteemed colleague, Dr. Chan Yoon Kim from Seoul, Korea. We have three distinguished speakers from India, Sri Lanka, and Bangladesh. Dr. Kim will introduce them soon.
And finally, Dr. Nazrul Islam will speak on drops to surgery, when and what. Please enjoy the whole presentation.
Good afternoon. I am Dr. Nazrul Islam from Bangladesh Eye Hospital and Institute in Dhaka. I am really grateful to the Asia Pacific Glaucoma Society and Allergan for the opportunity. I do not have any financial disclosure. I am very happy to find my three good friends, Dr. Shirisha Senthil, Dr. Dilroani Arayasinghe, and Dr. Kim. We had so beautiful memories before the COVID time. Well, in next few minutes, I shall share my presentation on drops to surgery. When and what kind of surgery. If you look to this triangle, the treatment of open-angle glaucoma is anti-glaucoma medications, laser, and surgical treatment. Now the question is when you are to change from drops to surgical treatment. To know that, we have to set the target IOP for every individual patient. And definitely, you need lower target IOP when there is glaucoma damage is higher, life expectancy is more, there is low untreated intraocular pressure, and progression is faster with some additional risk factors. Regarding the target pressure, Asia Pacific Glaucoma Guideline, 3rd edition, has given good guidelines. When the glaucoma is with high risk progressive visual loss, you are to reduce the pressure at least 40% or more from the initial pressure, and the target pressure should be 9 to 12 millimeter of mercury. If the glaucoma with moderate risk, then you are to reduce the pressure from initial pressure at least 30%. If the glaucoma suspect at moderate risk, you are to reduce 20%. Dr. Romanjit Shiota and Dr. Tanuj Dada et al., they also beautifully showed in a India Journal of Ophthalmology that if the glaucoma is having early, moderate, or severe, you have to keep the target pressure lower, like in early 15 to 17, moderate 12 to 15, severe 10 to 12 millimeter mercury. If we look to the literature, there is many formulas to set the target pressure. One of the modified formula of Jampel is the target pressure equal to initial pressure into 1 minus initial pressure divided by 100 minus Z plus minus 2. In this formula, if we consider the initial pressure is 25 and say glaucoma is glaucoma suspect high risk, Z is 1, then the target pressure should be 17.75 millimeter of mercury. If we look another formula, there is a variation of the Jampel formula, that target pressure can be maximum IOP minus maximum IOP percent minus Z. Similarly, if we consider 25 is the initial pressure, then target pressure comes to 17.75, exactly same like the previous formula. So you can take any formula where the target pressure can be set, can be calculated. And then we have to choose the when from drops to surgical treatment we must change. If you find a patient like this, the risk the target pressure, good compliance, stable structure in the disc, and good visual field and function, definitely the patient can continue medical treatment with maximum medical treatment. Do not need to switch over to laser or surgery. But sometimes the medication has disadvantages, like it may cause ocular surface disorder. Some patient cannot afford it is expensive. Affects patient general health also. Many patients have non-responsiveness to these drugs. And last but not least, the quality of life is reduced in the glaucoma medication. So, in some cases, we find the patient reaches the target pressure, stable structure and function, but the patient is having severe ocular surface disorder and poor compliance. Definitely, we have to change from drops to the laser or surgical treatment. Another few groups of patients like target pressure not reached with MMT, definitely you have to go for the surgical treatment. Some patient with poor compliance, some patient progression in structure and function irrespective of the good control of the IOP with the drugs. Even then, you have to go to the surgical treatment to make it a single digit IOP in future. These are the groups that need surgical treatment. When they first diagnosed as advanced glaucoma, like CD ratio 0.8, 0.9, the visual field is very narrow, then of course you have to think of surgical treatment. Now the question is, what kind of surgery? Well, recently in the last decade we have different options including laser and microinvasive glaucoma surgery. If we look to the selective laser trabeculoplasty, it is one of the wonderful treatment because it is a cold laser. It, unlike the ALT, does not have any collateral damage, and it actually works and does not cause any harm. And in numerous studies, it is found that it reduces the IOP as PG analogs like latanoprost. Many authors have found that it reduces the IOP from its initial pressure from 11% to 40%. Very recent study published in this month in the American Journal of Ophthalmology, the LIGHT study, in China, they found this selective laser trabeculoplasty as a first line of treatment. In 2015, I had a comparative study between the phakic eyes and pseudophakic eyes. The SLT works in both groups. We found more than 22% reduction of pressure in 74% in the phakic group and 69% in the pseudophakic group. So in our population also it works. Now coming to the different surgical treatment. Dr. Aik Ahmed given this plot of surgical treatment, different surgical treatment and in which group of works. Say in the early glaucoma, SLT works, trabectome, eye stent, Kahu dual blade, they work. But in the light moderate cases, definitely eye stent also works. But you can go to the ab interno canuloplasty, GAT, Jane implant, canuloplasty like that. But when the glaucoma become advanced or the very advanced cases, then you see you have to do tube shunt or trabeculectomy. In some cases, recently in focus, Jane implant is doing good result. So definitely from this diagram, we can see that minimally invasive glaucoma has a role for the very early and moderate glaucoma. But still, the advanced glaucoma cases, trabeculectomy, tube shunt are the answer. So, minimally invasive glaucoma surgery is wonderful if we have the facility in our region. But unfortunately, in our region, in many countries, these MX are not available and not affordable by our patient. But of course, if we have the facility, we can utilize these beautifully devices and stents so that we can treat our patient even without drops in the early glaucoma and moderate glaucoma cases. I had little experience with the eye stent that I got from one of my American friend, and with their guidance, I did few cases, and definitely the eye stent and the eye stent eject gives very good result in the mild to moderate cases. In many studies, in the literature, it proves that it's quite safe in the patient after the cataract surgery. If you do in the mild to moderate glaucoma cases, they can maintain the target pressure for many years. Well, Kahook dual blade is again a good mix that you can excise a part of the trabecular meshwork. It is a dual blade, so it cuts very nicely, excise the trabecular meshwork. And again, I had the opportunity to have few Kahook dual blade from one of my friend, and I used it, and actually it works. But in some cases, in about 10 cases, I had to do trabeculectomy after a few months in 2 cases. So definitely in advanced glaucoma it doesn't work, but in early to moderate glaucoma you can use the Kahook dual blade. And hyphema is one of the complication, but of course you can wash it and you can maintain the pressure with higher pressure. Now coming, the bent aventino needle goniectomy is one of my favorite surgery, and I do it because it doesn't have any expenditure. If we have a direct gonioscope, you can do it with simply by 27G needle. There is only few cents cost, unlike the other mix. So the same like the Kahook dual blade, you make your knife bent a little bit and excise the trabecular meshwork, first the 50 to 60 degree, then another part 50 to 60 degree. So totally 100 to 120 degree. You can excise the trabecular meshwork, and it also works. Arsham Saibani et al. Found in their study, and Arsham Saibani is the inventor of the Bang procedure, and in their procedure they found it is very economic and cheap MIGS, which is equivalent in the reducing the intraocular pressure. Well, in moderate to advanced glaucoma, usually the mix do not work much, but we need filtration surgery, trabeculectomy, or tube shunts. In some places, micropulse laser, diode laser also being used in this group of patients. In the recent study of the primary tube versus trabeculectomy also showed that trabeculectomy is still the gold standard for reducing the IOP. Even it works better than the tube, where the trab success rate was 72% and tube success rate was 67%. So trab is still very useful surgery for the advanced glaucoma cases. So in trabeculectomy, surgeons have their own choice. Some people do triangular flap, quadrangular flap. It has no significant difference of the result. I make quadrangular flap 4x4 usually, and make the half thickness. Of course, in the angle closer glaucoma, I make a little thicker. I go about 1 millimeter off to the limbus. So I enter with the 15 degree needle. I use the Kelly's pars forceps to excise the trabecular meshwork and also the peripheral cornea. I do the broad base iridectomy, then suturing with the T&O nylon and closing the conjunctiva watertight by 8O Vicryl horizontal metascissor from one corner to another corner. And then patency test, of course, and closing the surgery. Yes, sometimes the trabeculectomy also fails. So then we are to choose different kind of surgery. In tube shunts are the right answer in this group of patients. We have different group of tubes: bulbed one, non-bulbed one, Ahmed glaucoma bulb, valved bulb, Orbind aqueous drainage implant RD, then Paul glaucoma implant, Ahmed clear path. So it's the surgeon choice who wants to use which valve or the non-valve devices. Definitely the valved or non-valve device has its own advantages and disadvantages. So depending on the patient's requirement and indication, the valved and non-valved devices are usually chosen. So this is the Paul glaucoma implant, and it has another extra advantage. Its tube is narrow, 30 gauge. So whenever the tube goes to the anterior chamber, it takes very little space. So there is very little chance of touching the cornea or the iris, unlike the 23 gauge tube of the Ahmed bulb or the barbed implant or the RD implant. And I find it is really useful even in the angle closer glaucoma cases, where the SC is sometimes very shallow. So it can also accommodate even in the shallow entry chamber in the angle closer glaucoma cases. So tube shunt is an alternative method for doing the failed or the refractory glaucoma cases. Well, micropulse laser is being used more popularly now in different centers, even in the developing country. And it has advantage that you can treat not only the advanced glaucoma, also the early, moderate, and also advanced glaucoma cases. Lastly, the diode laser photocoagulation can be used in the advanced glaucoma cases, and mostly it is very important to use in the painful blind eye from glaucoma, neovascular glaucoma end stage without vision, so that the patient pain become decreased, pressure become reduced. So in short, these are the indications when we want to change from drops to different kind of surgery for different kind of glaucoma. Thank you so much.
Thank you for all speakers for nice presentation. There are many questions from audience, and especially many questions are for Dr. Arya Singha. The first question is, what are the limitations of ocular hypertension treatment study? What are the limitations, Dr. Dilwani?
Yes, the limitations of ocular hypertension treatment study include their study goal was to achieve 20% reduction in IOP in subjects. So it may not be sufficient to protect them from primary open-angle glaucoma. So, and also there was no measure of medication adherence in those patients. In addition, the sample was a convenient sample and not a population-based epidemiological sample. And also the participants were considered as completely healthy right at the beginning. So those were the main limitations of the ocular hypertension treatment study.
Thank you. There are many questions to ocular hypertension treatment study. So second question is, what are the factors favoring treatment outcome in ocular hypertension treatment patient? What are the favorable factors for treatment in ocular hypertension treatment study? Dr. Arya Singha, please again.
Yeah, factors favoring the treatment in ocular hypertensive patients include increase untreated IOP, the baseline IOP. If the IOP is very high, then it's a high risk factor. Then increase vertical cup to disc ratio. Then older age has a higher risk of primary open-angle glaucoma, particularly if their life expectancy is high, and reduced corneal thickness. Thinner corneas have a higher risk of developing primary open-angle glaucoma in ocular hypertensive patients. Also, if the fellow eye has primary open-angle glaucoma, we can consider that as a factor in favor of treatment. And if the patient's fellow eye has poor vision, then we can consider treating the eye with the ocular hypertension.
The third question is, what is the outcome of a European glaucoma prevention study? Dr. Arya Singha, you presented a little bit about the European glaucoma prevention study, and what is the outcome of that study?
European glaucoma prevention study was actually designed to evaluate the efficacy of reduction of intraocular pressure by using dorzolamide in preventing or delaying the primary open-angle glaucoma in patients with ocular hypertension. So these patients were randomized to treatment with dorzolamide or treatment with placebo. And the conclusion was the dorzolamide reduced the pressure by about only 15 to 22%, and the EGPS actually did not or failed to detect a statistically significant difference between medical therapy and the placebo group in reducing the incidence of primary open-angle glaucoma in ocular hypertensive patients.
Oh, thank you. And next question is to Dr. Senthil. How does central cornea thickness influence intraocular pressure measurement?
Unmute, please.
Yeah. So the fact that the central corneal thickness has gained so much of importance is, I think, the credit goes to the OHTS study. But so how do we use it in clinical practice, and how does it influence the intraocular pressure? So if the Goldman applanation tonometer is the gold standard for intraocular pressure estimation in our clinics, and the central corneal thickness actually affects the way the intraocular pressure is measured by GAT. So when Goldman designed the tonometer, he assumed that everybody's corneal thickness was possibly an average of 520, and hence an corneal thickness that is above 520 or less than 520 has an influence on the way the pressures are recorded. So thicker corneas, we overestimate the intraocular pressure. Thinner corneas, we underestimate the intraocular pressure with GAT. And the same holds true even for other tonometers. So anything that is through the cornea, because you measure an indirect estimation of intraocular pressure over the ocular surface, that is on the surface of the cornea, and corneal properties, and especially the corneal thickness and the other biomechanical properties definitely influence the way we record the intraocular pressure.
Oh, thank you. This is my question. There are many persons to receive laser refractive surgery. And how do you measure the intraocular pressure in such patients in your clinical practice? Dr.
Yeah. Thank you, Dr. Kim. That's a wonderful question. I think this is one of the biggest challenges that we face. So high myopic eyes are more prone for glaucoma. It's very difficult to estimate glaucoma in these patients, and more so if they undergo a refractive surgery, which has remodeled the cornea, it is even more difficult for us to estimate the intraocular pressure in that. So there are several factors that people talk about, but with whatever experience that I have in treating these patients, I would say that if somebody has a suspicious optic disc and has a positive family history of glaucoma, visual fields have to be done on a regular basis. That's the only thing that will tell you whether there is any functional change happening or not. And of course, the structural tests do help, but to some extent. The measurement of intraocular pressure, whichever tonometer is used, I think it's important to use the same tonometer over a period of time. So somebody was recorded 14, 15 intraocular pressure, and let's say 3 years down the line or 5 years down the line, the pressures are in the range of 20s or 25. So obviously, the pressures are going up. So then, you treat. But if somebody's pressures were 10 and 12, and they're only about 14, 15 or 16 now, but disc is showing changes, that is where we get into confusion. So in these cases, I think we know that we underestimate the intraocular pressure. So for me, intraocular pressure estimation is essential to understand how we treat it and how much to lower. But whether there is glaucoma or not, I think that we have to diagnose by the structural evaluation and, of course, by doing a visual field test to know if there is a functional loss. So CCT has to go hand in hand with intraocular pressure estimation and structural evaluation and functional tests. So it's a complex answer to that question that you asked.
I have a question to Dr. Sirisha, with permission of Dr. Kim. Here is a question that a patient having normal tension glaucoma and estimation of target pressure is about 12, but the patient is having 16. With 3 medication, their pressure doesn't come less than 14. So how to manage this case? Because pressure is controlled within normal, but still there is progression. Patient is having progression for lifetime. So what is your suggestion treating this case? Because even with 3 medication, the IOP is not coming to that target pressure.
Yeah, thank you, Dr. Nazrul Islam, and good to see you.
Thank you.
So I think what I have put together in the presentation were actually all the clinical types of cases that we come across on a daily basis. So I would say rule out angle closure. I'm sure if you are treating it, you would have definitely ruled that out. And look at all the other associated risk factors. So these are patients who actually will require a little bit of our time. Sit with them, speak to them, understand their lifestyle. In fact, I can give you an example of a doctor who was going to a gym in the recent past, and he was progressing. It was one night and he was progressing, and he was telling me that when I kept on asking him questions, he was actually on some diet supplements that had a steroid. So until which level do you grill to find out what their daily, lifestyle is like and what changes have happened in the recent past, I think is very, very important for us to know whether is there an additional steroid that they're using, is there a systemic factor that is causing this problem, is there an ocular factor, like instilling the drops. So for me, I would say that if they're not instilling the drops well, they're not working.
Yes.
So
Yes.
as simple as that. So ocular, systemic, as well as their behavioral and lifestyle changes, I think we need to rule out before we say that we give up on them.
Thank you. I have another question, Dr. Dilrani. The patient, you have already nicely told, very excellent presentation about ocular hypertension study, and it showed that you need to treat some of them, otherwise it will progress. So is there any role of SLT in reducing IOP in case of ocular hypertension?
Actually, there's a recent study coming up, as you mentioned, the light one in UK and one in China. So they have actually proven the benefit of SLT in as a primary treatment in ocular hypertension, also in glaucoma. So there is a role of SLT in ocular hypertension. Yes.
Thank you.
Thank you.
Dr. Kim.
Oh yeah, there are many questions from audience, and
I have one, I think I find one question to me. I find here wonderful
Yes.
surgery by Dr. Slama when you go for primary tube indication in your hand and your important take-home message on any specific tube. Very nice question, and thank you so much. I think first of all, we try not to be the primary surgery tube in our context in Bangladesh, but still in some cases, say in neovascular glaucoma, in inflammatory glaucoma, eye syndrome, we know that trabeculectomy failure is very high. The success is very low. So definitely in these cases, you can try the primary tube surgery. This is my choice. And my personal choice is the valve one, the Ahmed glaucoma valve, because I find more comfortable after doing the Ahmed glaucoma valve. I can control the patient pressure nicely. But for the Barvelt or the RD, you have to tie the tube, and definitely post-operatively there might be some higher intraocular pressure. And in the very advanced glaucoma cases, that cannot be really expected, might have some more progression. So definitely my choice is the valved one. And for myself is the Ahmed glaucoma valve. Thank you for the question. Dr. Kim, please.
There are still many questions, but we should have last questions. There are many questions about the relationship between blood flow and glaucoma. So would you sum up about the systemic blood flow and glaucoma? Please answer that question, Dr. Senthil. Yes, please.
Thank you. So ocular blood flow plays a very important role as far as the glaucoma occurrence as well as the progression is concerned. So when there is, more importantly, a dysregulation, a vascular dysregulation and autonomic neuropathy, these are two important factors that can actually cause this problem. So whenever there is a hypoperfusion, decreased blood flow, and then there is a reperfusion, so you have this hypoperfusion, reperfusion, because of which there is also a lot of damage, free radical damage, nitrous oxide that gets released and things like that. So that causes ultimate damage to the retinal ganglion cells.
Oh, thank you. Unfortunately, we are beyond the time schedule, so I will close this webinar and thank all speakers and participants for this webinar. Thank you.